Thank you very much, Louis, and thank you for standing in for me on that side of the court, I have to say. So it's a privilege to be here. I have a few conflicts of interest to declare. I'm Associate Editor at BJSM. I got a little bit of research funding from Kellogg College in Oxford for some of the work that I will present and won't present. And I also am first author in the up-to-date paper on femoroacetabular impingement with Professor Sean Jones and Anthony Palmer on this topic. Watch this video and let's focus on the left hip of this triple jumper. World champion, multiple world champion, up to 4 times body weight with each step up and jump. Look at that hip. So athletes load their hips and they don't necessarily get injured. In fact, the vast majority probably won't get injured despite this type of load in a triple jumper. Rula will tell me if that's also the case in footballers, but I think triple jump is probably one of the most demanding hip sports in the world. So I hope after this Tuesday lecture you'll be able to define FAI syndrome, apply evidence-based terminology when as it's related to when communicating about FAI syndrome and its related bony morphologies, and finally construct an evidence-based treatment plan for an athlete with FAI syndrome. So first of all, I want to focus on 3 concepts: evidence-based medicine, healthcare, working with patients, and PROMs, or patient-related outcome measures. That's really important when we then focus on FAI syndrome, what it is and the terminology to use, treatment options, and 2 or 3 slides on prognosis. And then finally wrapping up with a short clinical case and summary. So the godfather of evidence-based medicine, as he called it, and now perhaps evidence-based healthcare, is David Sackett. And this is the definition we usually see in talks and in books. Evidence-based medicine is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. And Guido last week emphasized individual patients, and it's in the definition of evidence-based healthcare. The practice of evidence-based healthcare is integrating this individual clinical expertise with the best available external clinical evidence from systematic research. And this is David Sackett's definition. However, as I've said, this is where most people stop. But I want to read to you 2 extracts from his seminal paper in 1996 about what evidence-based medicine is and what it's not. So, individual clinical expertise is the proficiency and judgment that individual clinicians acquire through clinical experience and clinical practice. Increased expertise is reflected in many ways, but especially in more effective and efficient diagnosis and in the more thoughtful identification and compassionate use of individual patients' predicaments. I love the word predicaments, and you can look it up. It's a formal word for an unpleasant or a confusing situation that's difficult to get out of or to solve. So individual patients' predicaments, their rights, and their preferences in making clinical decisions about their care. What a wonderful definition of clinical expertise or individual clinical expertise. And then it goes on, best available external clinical evidence, clinically relevant research, often from the basic sciences of medicine, but especially from patient-centered clinical research into the accuracy and precision of diagnostic tests, including the clinical examination, the power of prognostic markers, and the efficiency and safety of therapeutic, rehabilitative, and preventative regimens. And today we would add to that qualitative research on patients' experiences. And this is the figure that we normally see. So best available evidence, clinical judgment, and patient values informing shared decision making. And watch this space. Sophie Neelis in the back there is doing a PhD on shared decision making in elite athlete healthcare. We have very little in this domain. But we also have rubbish evidence-based medicine or evidence-based healthcare. And what is rubbish evidence-based medicine? You can read about that, and Tricia Greenhalgh has published a lot on that. But first of all is when we cite numbers from population studies without asking upstream questions about where those numbers come from. Or if we apply cookbook evidence-based medicine, so we think that the published evidence equals our patient's need, or have little regard for the patient's perspective, or if we fail to acknowledge the significance of clinical judgment. And of course, rubbish evidence is evidence draws on rubbish research, and a lot published on research waste over the last 20 years, and it's not really improving also in this space. Words do matter. Different terminology given for the same condition influenced the management preferences and psychological outcomes in a consistent pattern in this systematic review. And in this space, words definitely matter. How we frame a problem or a condition as a clinician to a patient is extremely important. Practicing good evidence-based medicine or evidence-based healthcare, we must embrace authentic and trustworthy and trustful partnerships with patient athletes, their families and their coaches. So not only our words, but also our non-verbal communication influences what the patient might decide about a treatment. As this study illustrates, the physical examination in cosmetic surgery, communication strategies to promote the desirability of surgery. Fantastic qualitative paper by Julian Miraval. Through our non-verbal communication in this study, surgeons constructed the patient's body as a territory of surgical need. Strong words, and I urge you to read this paper and then reflect. Do we, through communication, verbally or non-verbally, construct the need for an injection or for surgery or for whatever treatment we want to inflict on the patient? And finally, a few words on PROMs, or patient-related outcome measures. And this is important because several of the studies that I'll refer to later on use PROMs. And many of you know exactly what a PROM is. It's a tool that we use in clinical practice, but especially in research, to gain insight from the perspective of the patient into how aspects of their health and the impact of the disease and its treatment are perceived to be having on their lifestyle and subsequently their quality of life. So the important thing about a PROM, or a patient-related outcome measure, it's from the patient's perspective. It's not a surrogate outcome measure, which might be a thing that we see on a scan over time that might be important to us, but might be completely irrelevant to the patient in front of us. And I want to highlight this specific PROM, the 33-item international hip outcome tool that is used in the hip-related research that I'll refer to. This is, as it says, 33 questions in 4 domains. Domain 1, symptoms and function limitations. The second domain, sports and recreational activities. Third, job-related concerns. And finally, social, emotional and lifestyle concerns. And importantly, only 6 questions out of 33 in category 2, sports and recreational activities. What does the participant in the research or the patient do? They're asked to place a mark on this visual analog scale line for each question, with extremely difficult on the far left, as you can see, and not difficult at all on the far right. And then we measure the distance in millimeters of that line for 33 questions, divided by 33, and you get a score out of 100. So 100 millimeters in 10 centimeters, if I'm correct, and that's the score, or IHOT score. And then typically in an RCT, you'll get a physiotherapy group with a baseline average IHOT score, and a surgical group with a baseline IHOT score, and then the IHOT score is measured at 6 months and at 12 months, and that outcome is then used or population outcome is then used to say physiotherapy or surgery is the better treatment for this population in the RCT. So with that, let's quickly dive into FAI syndrome, the definition, terminology, and treatment options. We all label others, and we are labeled. And I think as healthcare practitioners working in orthopedics, sports medicine, and science, we are probably collectively guilty at labeling patients with a condition or a disease when it's not necessarily needed or helpful. If I ask you, how would you label this person? Exactly. So 2 days ago, he unfortunately ruptured his right Achilles tendon in a football match, but that's not what I wanted to say when I put this slide up, and we wish Usain Bolt a speedy recovery. But you might say he's the world's fastest man ever. He's a world record holder, multiple Olympic champion, can't even count how many Olympic medals, etc. Or do you label him as someone with quite severe scoliosis? And he tweeted about this and said, I couldn't let scoliosis stop this dream. So I want to argue that the term FAI, or femoroacetabular impingement, labels healthy people with something that they don't have. It's not a useful term. Guns, 20 years ago, thought differently, and I think we've moved on. He defined FAI as the abnormal contact that may arise as a result of either abnormal morphological features or as a result of subjecting the hip to excessive and supraphysiological range of motion. A good definition, but we've moved on. The bony bump at the hip has also been called a tilt deformity. The word there by Murray, Duncan and Solomon. Solomon, a South African orthopedic surgeon in 1976. Or a pistol grip deformity. I'm sure you've seen that in the literature too. And this paper used 10 different terms in one paper for the same condition. So I think you'll agree that this is hugely confusing, not only for those reading the paper, but also the clinicians working with athletes and patients with this specific condition. So a group of us, dare I say predominantly white males from the global north, got together in Warwick to discuss this, and we agreed on the Warwick Agreement on FAI syndrome. And this is what I'll focus on for the next few minutes. This was published in the British Journal of Sports Medicine in 2016, and very highly cited paper with an infographic describing what FAI syndrome is, how we define FAI syndrome, and what the treatment options are. The important outcome of this agreement is we agreed on terminology to avoid and terminology to use. FAI syndrome is the term that we will use, and we will avoid asymptomatic FAI, symptomatic FAI, or FAI morphology. And when we speak about CAM morphology or pincer morphology, that's what we use. We don't use deformity, abnormality, lesion when referring to CAM or pincer morphology. And I hope you can see now how using those terms might construct the need for an intervention where it's often not needed. So FAI syndrome is a motion-related clinical disorder of the hip with a triad of symptoms, clinical signs, and imaging findings. So you need all three to make the diagnosis of FAI syndrome, representing symptomatic premature contact between the proximal femur and the acetabulum. Emphasis on symptoms. So motion-related hip and groin pain is the primary symptom of FAI syndrome. Patient may also have pains in the buttock, the back or thigh, and they may describe a clicking, catching, locking, stiffness, or restricted range of motion or giving way sensation. And I often in clinical practice have patients telling me they just feel restricted in their hip, not necessarily, or stiff, not necessarily pain. And the diagnosis of FAI syndrome doesn't depend on one single clinical sign or test in the room. I highlight here the one that I find really useful. It's sensitive but not that specific, is the FADER test, hip or so-called hip impingement test, flexion, adduction, and internal rotation. As I've said there, sensitive but not specific. And also hip range. In these patients, internal rotation is often limited. And radiographs only should be used to diagnose FAI syndrome, AP and lateral femoral neck radiographs. We don't need any cross-sectional imaging as a standard. Don't need an MRI, don't need a CT scan, unless we want further assessment of the hip morphology and associated cartilage or labral pathology, and especially maybe if there's a surgical discussion or symptoms that point to a large labral tear or something like that. Otherwise, by definition, you need only radiographs. And this is what it might look like. You might agree that there's a bony bump in both hips at the femoral head-neck junction, and we use the alpha angle to measure the size of that bony bump. And if you want to read more, read this concept analysis that I published in 2020 on primary cam morphology, my pet hobby for my PhD, and I'll do my best not to dive into too much detail about this pet hobby of mine. Bump, burden, or a box standard, a concept analysis. And in this paper we gave this morphology 5 attributes: tissue type, size, location, shape, and who owns it, who has this morphology. And importantly, we decided to classify this condition or this morphology into primary and secondary cam morphology. And this is helpful in the clinic. So we proposed a new conceptual definition for the morphology, spotlighted some troublesome terminology even after Warwick, introduced the new taxonomy, distinguishing between primary and secondary cam morphology. Primary in an athlete where there's no pre-existing hip disease, for instance, like a slipped capital femoral epiphysis or avascular necrosis, for example, and exposed challenges of operationalizing hip morphology on imaging. Although we use the alpha angle, it's not without its limitations. And then grappled further with these uncertainties in a follow-up consensus that I've led and published, the Oxford consensus, and this is a topic for a Tuesday lecture on its own. I won't dive into the 2 Oxford consensus, the last one on a research priority setting for the field. So what are the treatment options for FAI syndrome? And I'll briefly refer to 3 of the seminal RCTs published in this space. The first one by Damien Griffin and group in 2018, published in The Lancet, hip arthroscopy versus conservative care for the treatment of FAI syndrome, or the UK fashion trial. And I want you to take note of how physiotherapy or physiotherapy-led incremental exercise rehabilitation has been referred to in the title. Here they call it conservative care with all its limitations. Anthony Palmer in Oxford with Professor Shaundran Jones, arthroscopic hip surgery compared with physiotherapy and activity modification for the treatment of symptomatic femoroacetabular impingement, multi-centered RCT. And then finally the Australian fashion multi-centered randomized controlled trial comparing arthroscopic hip surgery to physiotherapy-led care for FAI syndrome. And you can see terminology being played with in the titles of these 3 RCTs. The fashion on the far left use IHOT 33 as their primary outcome measure. The FATE trial, or the Anthony Palmer one from Oxford, use another PROM as an outcome measure, and you'll see just now, while the primary outcome measure for this Australian fashion trial was a surrogate outcome measure on a scan, the so-called degeneric over time on an MRI scan. And secondary outcome was IHOT and other scales. So this is the IHOT 33 results in the UK fashion trial. And if you look at baseline, you'll note that on average, the participants included in this RCT, both groups, the red, the hip arthroscopy group, and the blue, the physiotherapy group, had fairly low average IHOT 33 scores. That increased after 6 months post-intervention or while doing the intervention in physiotherapy, but not statistically significant, but perhaps clinically significant. And it increased more after 12 months. And there you can see, because the confidence intervals don't overlap, that it's slightly better for hip arthroscopy compared to surgery in this population. And this is the FATE Oxford trial RCT that used hip outcome score on activities of daily living, subscale, as the primary outcome. So it's a subscale of a PROM. I've mentioned that the IHOT has 4 subscales. The hip outcome score on activities of daily living is a subscale in this RCT. And you can see there as well, over time, the hip arthroscopy group did a little bit better than the physiotherapy and activity modification group in this trial. Now, RCTs are up there in terms of level of evidence when we talk about treatment, I think you'll agree. But one level up is a systematic review of RCTs in this space. And this was published by Giovanni Ferreira et al. And here I want you to focus only on the top bit of this systematic review. And you'll see the Griffin trial, if you start from the left, the 3 trials included here is the Griffin trial, and then a small Mansell trial in the military that I didn't include in the previous slide, and Anthony Palmer's trial. So they didn't include the Australian fashion yet in this systematic review. And a couple of things to notice. If you look at the Mansell trial and then go right to your right and see in the forest plot, you'll notice a very small green square. And that's rightly so, because the weight given to this trial is less than the other 2 trials. Why? Several reasons, but predominantly it's a small trial. You'll notice there's only 37 in each group. If you look at the hip arthroscopy and the non-operative groups, 37 in the Mansell trial. While the Griffin and the Palmer trials are more important, more weight given in this systematic review, so the green squares are larger in this forest plot. And then if you look at the black diamond, the summary estimate, you'll notice that on average, the surgical patients improved more over time, so their mean IHOT score improved more over time. But then so on average 11, if you look at this, but then look at the confidence intervals, not all patients improve, while some improve a lot. And this is important. But there's a problem. And the big problem one of the big problems in RCT is fidelity. So you can think, if you do an RCT, but the intervention in one group is suboptimal compared to the other group, then you'll get a better result in the group where the intervention was good or great. Now, a big group of physiotherapists questioned the quality of physiotherapy given to the physiotherapy groups in these 2 trials, led by Professor Joanne Kemp and last author Professor Kay Crossley. This was published in the British Journal in 2019. Big question mark over the quality of physiotherapy in the RCTs, and it's certainly far from the physiotherapy that we provide here at Aspetar to patients with FAI syndrome. So important. So Professor Joanne Kemp and group then started this trial, the physiotherapist-led treatment for FAI syndrome, or the Physio First study. And this study compared strength training, group of exercises, with stretch training in patients with FAI syndrome. This study is complete. It's not been published yet, but Professor Kemp delivered the results of the study at the Isokinetics conference a few weeks ago, and she's going to do a keynote on this study at this conference that Louis mentioned, the Young Athletes Hip Conference and Workshops in Oxford in September, where Joe will discuss the results of the Physio First trial, and in one sentence, a huge improvement in both groups from baseline to 12 months using the PROM, IHOT 33, but more so in the strength group compared to the stretch group. I'll say no more. Come to the conference or join us online. But athletes might be interested in the prognosis of my condition, and they'll ask you, if I go for surgery, what will happen afterwards? And Lasse Ishøy with the Danish colleagues look at the big hip arthroscopy Danish registry and extracted 189 athletes from this registry and looked at what happened to these athletes. Only 57% of the athletes who had hip arthroscopy returned to pre-injury level of sport, and of this 57%, only a third had optimal sports performance after hip arthroscopy. So 1 in 5 of the total population of 189 athletes had optimal sports performance after hip arthroscopy. And this is a really important message when we discuss hip arthroscopy with our patients in clinic, to give them realistic perspective on what might be the consequences or the prognosis after hip arthroscopy. But The other down-the-line consequence of FAI syndrome, and specifically morphology or primary morphology that's causally associated with hip osteoarthritis, has been dealt with in these two very large cohort studies, the Chingford and the Czech study. The Chingford is a 20-year prospective cohort study of 1,003 female patients. And it's interestingly, in this group over 20 years, each degree increase in the alpha angle above 65 degrees, and you now know what an alpha angle is, led to an increase of 5% for radiographic OA, surrogate outcome measure, you'll know by now, and 4% for total hip arthroplasty in this study period. So the alpha angle and the size of the alpha angle is an important metric in this study. The Czech was a 5-year prospective cohort study, 865 participants, predominantly female, age 45 to 65. And again, the alpha angle above 60 degrees had an adjusted odds ratio of nearly 4 for developing end-stage hip osteoarthritis in the 5-year study period. And if you have a large alpha angle, more than 83 degrees, combined with internal rotation less than 20 degrees, that adjusted odds ratio goes up to 25 times the risk of end-stage hip osteoarthritis in a 5-year period. No, not athletes, it's a large population, but I think important numbers to have in your mind when you see an athlete in front of you, for instance, with a large, with FAI syndrome, a large morphology, and internal rotation of 5 degrees or 10 degrees. So I'm going to end this Tuesday lecture with a brief look at a clinical case and then wrap up with a few polls. So you might see one of these athletes in your clinic complaining of hip-related groin pain or anterior groin pain. And this might be the radiograph, the lateral hip radiograph, and that is the bony bump at the femoral head-neck junction. So what will you tell this athlete? He's symptomatic, or they are symptomatic. What's the diagnosis? And I hope you'll agree, FAI syndrome is the diagnosis. But FAI syndrome, if there's no pre-existing history of hip disease with primary morphology. And I'll do two things in the clinic. I'll tamper down the syndrome bit of the diagnosis, because athletes might hear syndrome and think, oh my goodness, I'm going to die. And this was what we had from the athlete partners in our Oxford consensus study. They don't like the word syndrome. So we need to discuss the word syndrome in this diagnosis. And I find it really helpful to also discuss primary. So you don't have necessarily this hip disease. This bump is normal in the athletic population. We know the prevalence in football, the prevalence in track and field, the prevalence in ice hockey is very high for primary morphology. So you might also see an athlete, and this athlete might have a radiograph where you pick up the morphology, but they are asymptomatic. So say the athlete present with a symptom not related to their hip, and you do a radiograph. What do you tell them then? And we'll downplay the morphology. I certainly do in my clinic, and tell them nothing much will happen. You will have a happy hip for the rest of your life. You'll probably die with this, and nobody will, most athletes won't even know that they have this bony morphology. And Andrea Mosler, in a 2-year prospective code study on the Qatar Stars League, proved this. 84% of hips defined as having primary morphology did not become painful in this 2-year study period. Granted, 2 years is not a long time in an athlete career. They might develop pain later on. So the challenge is to identify those at risk of developing end-stage hip osteoarthritis at an early, relatively early stage in their career. And I've given you some pointers that might help us to do that. And watch this space. There are studies that will be published later on this year and maybe early next year to give us more numbers that we can bring to our athlete clinic. But this is perhaps where the athlete is that I've just discussed. So in the disease continuum, they will start with subclinical hip disease, and when they develop symptoms, we make the diagnosis of FAI syndrome. Some of them will develop hip osteoarthritis, and some of them will have hip replacement surgery down the line. And for each of these conditions, they might go into nothing much happens, or they might go into debilitating pain, the small minority, or struggle from time to time, the yellow line there, but they cope. You've all seen patients running a marathon with a replaced hip, so that can happen, or continue to play sport after a replaced hip. And this is especially challenging when young patients have hip replacement surgery. What do we advise them in terms of sport for the rest of their life? If they have a hip replacement for a vascular necrosis of the hip at age 22 or 23, what do we tell them in terms of sport to protect the longevity of the hip joint? And these are the questions that we will be discussing in 3 months' time in Oxford. And we know that subclinical hip disease doesn't really, and this is in the title, relate to symptoms. So Josh Heery published this paper, Morphology size, and in this paper that he published, morphology size was associated with cartilage defects and labral tears in young adult football players, importantly with and without pain. So the fact that we see a cartilage problem on a scan or a labral tear doesn't mean that that's the culprit causing the pain. And this is an important message to patients as well. So the evidence-based approach to FAI syndrome in the athlete is not easy. We need more research in a number of areas, and specifically long-term prospective studies in athletes and perhaps also in elite athletes. The Danes are doing well with their hip arthroscopy registry, and we've certainly learned a lot from the work that they've published. And Lasse Ishøy earlier this year also published a paper, and we're probably close to predict who will have a non-optimal outcome after surgery. He's published a really nice paper on a prediction model for non-optimal outcome after hip arthroscopy surgery, with its limitations, but kudos to Lasse. So the first poll is, as I've mentioned at the beginning, we need to apply evidence-based healthcare to the individual patient. Patient preference, clinical expertise, and the available evidence. It's not easy, especially if the available evidence are population numbers in non-athletes that we then need to bring to our clinic. And especially if there's a problem, as I've said, with the fidelity or the quality of an intervention in an RCT, then it's difficult to bring a good study like an RCT with high internal validity, as we say, to our clinic. And that's the problem of RCTs, is external validity. Words do matter. I want to suggest that we choose our words very carefully when we manage these patients in clinic. PROMs are often used in research and in clinical practice, but remember that they are not individual measures, and it's still a form of population average. FAI syndrome is a motion-related condition of the hip, representing symptomatic premature contact between the proximal femur and the acetabulum, with symptom signs and radiographic evidence. We only need radiographs, as I've said, AP and lateral, to make the diagnosis of FAI syndrome. No need for an MRI. I won't say bye-bye MRI, but certainly we can restrict the number of MRIs we order in this condition. And we should distinguish between primary and secondary morphology, especially in the clinic and when we discuss this condition with our athletes. And the first line of treatment should nearly always be physiotherapist-led incremental exercise rehabilitation for at least 3 to 6 months. And there might be here and there an exception to this rule. And I think this message will be stronger and stronger as we progress with better quality research in the rehabilitation space. And add to that activity modification sometimes as well. And then finally, most athletes do not return to optimum level of performance after hip arthroscopy. an important message, as I've said, in the clinic when you discuss treatment options with the patients. These are two studies that if you revisit the recording of this lecture that you might want to download. It's open access. And here's the infographic that I've published, and I've just discussed the top bit of this infographic. Again, you might want to download that and read the polls given in that infographic. We've discussed the three key concepts of evidence-based healthcare, working with patients, and PROMs, and how PROMs influence research. We've discussed FAI syndromes, terms to use, terms to avoid, and briefly visited a clinical case to summarize this. And I'll stop there and open for questions.